Okay, let's unpack this. Imagine a circulating tumor cell, right? It just arrived in the human liver.
Right.
And, well, by all conventional biological logic, it should just be destroyed.
Absolutely.
I mean, the Kupffer cell should clear it, or it should just starve in that low-oxygen venous environment. But instead, it basically chemically brainwashes the surrounding hepatic arteries.
It's incredible. It essentially forces the host organ to build this private high-pressure pipeline of oxygen and nutrients directly into the tumor bed.
Yeah, that biological heist, the complete subversion of human anatomy, is exactly what we are looking at today.
It really does completely flip our understanding of organ defense mechanisms right on its head.
Totally.
We are so accustomed to viewing organs as these highly regulated, compartmentalized fortresses. But the liver, particularly in the context of metastatic oncology, it operates as a massive physiological trap.
A trap, yeah, because of the blood supply.
Right. Its greatest evolutionary asset, which is its immense nutrient-rich blood supply designed for filtration, is precisely what makes it so uniquely vulnerable to malignant invasion.
So if you are joining us for this deep dive, you are well beyond the basics. You are likely in the trenches right now, preparing for your FRCS exams, or maybe defending your PhD thesis in surgical oncology or molecular biology.
Exactly. And our mission today is to really arm you with a masterclass on the metastatic hepatic microenvironment.
We are stripping away the surface-level algorithms today. We are going to dissect the underlying molecular signaling, the biophysics of our imaging modalities, and the specific hemodynamic shifts that dictate our most aggressive interventions.
Because the clinical reality demands this level of granular understanding. I mean, at the FRCS or PhD level, an examiner doesn't just want to know that you can prescribe a treatment.
Right, they want to why.
Precisely. They want to know that you understand the fundamental physics and the cellular biology making that treatment possible. And the liver accounts for nearly 25% of all cancer metastases.
That is just a staggering volume. A quarter of all systemic malignant spread terminates in the single organ.
It's massive. And while the liver is a common endpoint for, melanoma, sarcomas, and neuroendocrine tumors.
The true clinical titan here is colorectal adenocarcinoma.
Undeniably. The epidemiological math is just inescapable. Colorectal cancer is the third most common primary malignancy globally, and roughly 20 to 25% of those patients will develop liver metastases.
And even more critical for you as a surgical candidate to understand up to 25% of those patients present with synchronous disease.
Right.
Meaning the primary bowel tumor and the hepatic lesions are discovered at the exact same time.
And that synchronous presentation forces a really highly complex multidisciplinary decision-making tree. It also explains why 70 to 80% of patients with metastatic colorectal cancer have disease that is initially confined exclusively to the liver.
Which is wild when you think about it. And when we analyze the histologic breakdown of all those metastatic liver lesions, carcinomas dominate at 92%.
And of those, 75% are adenocarcinomas.
So you are overwhelmingly dealing with glandular epithelial malignancies of gastrointestinal origin.
Which means we need to trace the exact physiological route these cells take to arrive there.
Yeah, let's talk about the plumbing. To understand how to destroy these tumors, you have to understand the specific plumbing they use to survive. This brings us to the liver's dual blood supply.
Right, so the portal vein acts as this massive drainage basin, pulling venous blood from the pancreas, the spleen, and nearly the entire GI tract.
It is the ultimate first-pass metabolism route.
Evolutionarily, yes. This portal venous system is designed to allow hepatocytes to instantly process newly absorbed nutrients and, neutralize ingested toxins before that blood hits the systemic circulation via the inferior vena cava.
But pathologically, it acts as a direct, high-volume superhighway for malignant cells shedding from a GI primary.
Exactly. The liver's sinusoids are literally the very first capillary beds these circulating colorectal tumor cells encounter after they breach their primary basement membrane.
But surviving the journey is only half the battle, right? Once the metastasis actually physically implants in the hepatic parenchyma, we see this incredible hemodynamic shift.
It's fascinating.
A healthy hepatocyte derives the vast majority of its blood supply, about 75 to 80%, from the portal vein. The hepatic artery's main job in a normal liver is just to supply the cholangiocytes, the cells lining the biliary tree.
But the metastatic tumor completely rejects the portal vein.
Has to, right?
It does. The portal venous system is a low-pressure, low-oxygen capacitance circuit. A rapidly dividing hypermetabolic adenocarcinoma just cannot survive in that hypoxic environment.
So it initiates that massive neoangiogenic signaling cascade.
Yes, the malignant cells upregulate hypoxia-inducible factor 1 alpha, or HAF1 alpha.
Precisely. This localized VEGF gradient chemically recruits the surrounding hepatic arterial branches, basically prompting them to sprout these chaotic, highly permeable capillary networks directly into the tumor bed. The tumor literally rewires the local anatomy to hijack the high oxygen, high pressure arterial flow. I've always found it fascinating that the portal vein, despite being right there, just doesn't respond to those angiogenic signals in the same way.
Right, the tumor specifically selects for arterial plumbing. And it's that precise biological subversion that actually creates our therapeutic window.
Oh, because the tumor is entirely reliant on the hepatic artery, while the surrounding healthy functional parenchyma is happily surviving on the portal vein.
Exactly. We have a targeted delivery cyster built right in.
Uh-huh.
We can inject highly concentrated cytotoxic agents or radioactive isotopes directly into the hepatic artery.
So the tumor receives a devastating localized dose, while the normal liver tissue is largely spared because it drinks from a completely different physiological well.
Exactly.
We will definitely explore those trans-arterial therapies in depth later. But first, we need to talk about how we identify the enemy.
Molecular forensics.
Yes. Once we found a lesion in the liver via biopsy, we have to establish its true identity. A pathologist can't just rely on morphology, the physical shape of the cells, because a metastatic adenocarcinoma can look remarkably similar to a primary hepatocellular carcinoma, or HCC.
Right. Morphology is merely the gross macroscopic equivalent of cellular diagnosis. For a definitive PhD-level diagnosis, you rely on immunohistochemistry, or IHC.
We are essentially using engineered antibodies to hunt for specific antigen targets within the tissue, and the primary battleground here is differentiating a primary HCC from a metastatic adenocarcinoma.
And the definitive marker for this is cytokeratin 19.
Let's unpack the biology of cytokeratins for the listener because, they are heavily tested on these exams. These are intermediate filament proteins that literally form the microscopic skeleton of epithelial cells.
They are, and their expression profiles are highly conserved based on the embryological origin of the epithelium.
So cytokeratin 19 is strongly and specifically associated with glandular epithelial differentiation,
which is the absolute hallmark of an adenocarcinoma. Hepatocytes, conversely, originate from the hepatic diverticulum and do not typically express CK19.
So if you run an IHC stain on a liver core biopsy and it lights up brightly for CK19, the forensic evidence overwhelmingly points to a metastatic adenocarcinoma,
effectively ruling out a primary HCC.
Right. But the liver doesn't just trap carcinomas, it can trap mesenchymal tumors too, like gastrointestinal stromal tumors or GISTs.
And those require a completely different investigative panel because they don't form glands and they aren't epithelial.
For a suspected GIS, the focus shifts entirely to receptor tyrosine kinase pathways. Right?
Yes. The hallmark marker is c-KIT, also known as CD117.
This is a transmembrane receptor that, when mutated, remains constantly locked in an on position, driving unchecked cellular proliferation.
Exactly, and we corroborate this by staining for CD34, which is a hematopoietic progenitor cell antigen, and vimentin.
Vimentin being the primary intermediate filament found in mesenchymal cells.
Spot on. And finding that c-KIT positivity isn't just an academic exercise.
Oh no, it alters the entire trajectory of the patient's life.
If you prove it's a JAST, you completely abandon standard systemic chemotherapy and utilize targeted tyrosine kinase inhibitors like imatinib.
Because imatinib specifically binds to the ATP binding pocket of that mutated KIT kinase, just shutting the signal down entirely.
That is the exact clinical correlation an examiner is looking for. You must connect the molecular marker to the mechanism of the pharmaceutical intervention.
Definitely. And we see a similar necessity for precision with malignant melanoma, which is the great masquerader of pathology.
Oh, absolutely. Through a process very similar to epithelial mesenchymal transition, metastatic melanoma cells can lose their contact inhibition and morphologically mimic carcinomas, sarcomas, or even lymphomas.
Which is why we rely on neural crest markers. The highest sensitivity marker is S100.
Right. These are calcium-binding proteins heavily expressed in cells derived from the neural crest, including melanocytes.
But S100 is almost too sensitive, right? I mean, it lacks specificity.
It does. So we have to deploy a targeted panel, HMB45, Melana, and MART1.
Those are highly specific melanocytic differentiation antigens.
Correct. If those nuclear and cytoplasmic markers are present, you have a metastatic melanoma. regardless of how deceptively the cells are arranging themselves on the slide.
Okay, moving to neuroendocrine tumors, the molecular logic shifts to secretory mechanisms. These are tumors capable of releasing massive amounts of vasoactive peptides.
Which causes devastating systemic syndromes. Our IHC panel targets the physical infrastructure of that secretion.
So we stain for synaptophysin, which is an integral membrane glycoprotein found in presynaptic vesicles.
And chromogranin, a protein found at the core of dense core secretory granules. We also look for CD56, the neural cell adhesion molecule.
And the coordinate positivity of those three markers definitively locks in the neuroendocrine diagnosis.
Exactly.
I want to pivot back to the adenocarcinomas, though, because this is where the exams get incredibly specific. We established that 75% of liver metastases are adenocarcinomas. But a colon cancer, a lung cancer, and a pancreatic cancer are all technically adenocarcinomas. How do we forensically prove the colon is the primary source when the biopsy is taken from the liver?
This requires a deep understanding of midgut versus hindgut embryology, which is reflected through the coordinate expression of cytokeratin 7 and cytokeratin 20.
Okay, so colorectal adenocarcinomas are classically CK20 positive and CK7 negative.
Right. A metastatic adenocarcinoma from the lung or breast, however, is typically CK7 positive and CK20 negative.
That simple dual stain basically bisects the entire diagnostic algorithm.
It really does. And while we are discussing the molecular origins of colorectal cancer, we have to address why right-sided colon cancers behave so fundamentally differently than left-sided colon cancers.
Especially when they metastasize to the liver. The literature heavily emphasizes that a right-sided primary is a significant poor prognostic indicator. Why is geography inside the colon dictating survival outcomes in the liver?
It is a brilliant question that cuts right to the heart of molecular oncology. The right colon, so the ascending colon and proximal transverse, derives from the embryological midgut and is supplied by the superior mesenteric artery.
And the left colon derives from the hindgut and is supplied by the inferior mesenteric artery.
Right. Because of these distinct developmental pathways, right-sided tumors frequently develop through the serrated pathway.
Oh, heavily involving the CpG island methylator phenotype, or CMP.
Exactly. This leads to a high frequency of BRAF mutations and microsatellite instability. Left-sided tumors typically follow the classic chromosomal instability pathway driven by APC and KRAS mutations.
So when a BLF-mutated right-sided tumor metastasizes to the liver, it exhibits a far more aggressive chemoresistant biology than its left-sided counterpart.
Yes. It's incredible how embryology dictates oncology decades later.
It really is. And just to round out the IHC toolkit, if the pathologist suspects a lobular breast carcinoma has seeded the liver, we are immediately staining for estrogen and progesterone receptors.
Right, because confirming those nuclear receptors allows us to deploy endocrine-targeted therapies like aromatase inhibitors. Every single stain must dictate a therapeutic action.
Absolutely. So once we have confirmed the exact molecular identity of the tumor, we have to map its physical macroscopic boundaries. You cannot plan a surgical resection or a radiation field based on a microscopic biopsy.
No, we need spatial volumetric data.
Which brings us to advanced diagnostic and functional imaging. And the absolute workhorse here is the triple-phase CT scan.
It perfectly visualizes the hemodynamics we discussed earlier. The three phases are the non-contrast phase, the arterial phase, and the portal venous phase.
When we administer intravenous iodinated contrast, it hits the systemic arterial circulation first.
And because the metastatic lesions have hijacked the hepatic artery, they just gorge themselves on this contrast-rich arterial blood.
Right, so during this specific arterial phase, the metastases appear as brilliantly bright, hyper-enhancing lesions.
Meanwhile, the background healthy liver parenchyma is still relatively dark, waiting for its contrast to arrive via the much slower portal venous circuit.
Conversely, on the initial non-contrast study, the metastases are generally hypoattenuating.
Right. They appear darker than the healthy liver because metastatic tissue is often heavily fibrotic, desmoplastic, or centrally necrotic, rendering it less dense than functioning glycogen-rich hepatocytes.
The triple-phase CT is just vital for spatial orientation. A surgeon needs to know exactly how the lesion relates to the major vascular inflow and outflow tracts.
Is the tumor abutting the middle hepatic vein? Is it invading the right portal pedicle?
This imaging provides the raw data required to calculate the future liver remnant, a mathematical concept that dictates resectability.
We will dive deep into the future liver remnant shortly, but we have to acknowledge that CT scans have resolution limits.
Yeah, when we need extreme precision, especially for sub-centimeter lesions, we shift to MRI. And the physics of MRI provide a completely different tissue contrast profile.
Standard MRI relies on the relaxation times of protons in a magnetic field. Liver metastases typically have higher water content and extracellular edema compared to normal liver.
Consequently, they appear hypointense, or dark, on T1-weighted images and hyperintense or bright on T2-weighted images.
We use standard extracellular gadolinium-based contrast agents to assess vascularity, often looking for a characteristic peripheral rim enhancement.
Right, where the highly active, viable tumor periphery takes up the contrast while the necrotic core remains dark.
But the true game changer for FRCS candidates to understand is the use of hepatobiliary-specific contrast agents.
Like gadoxetate disodium, commercially known as Eovist. This isn't just fluid washing in and out of the extracellular space. This is functional molecular imaging.
The pharmacokinetics of Eovist are fascinating. Unlike standard extracellular gadolinium, Eovist is actively biologically transported across the cell membrane into healthy hepatocytes.
Oh, this is facilitated by specific membrane transporters, right? Namely the organic anion-transporting polypeptide receptors, OATP1B1 and OATP1B3.
Exactly. Once inside, the healthy hepatocyte processes the contrast and excretes it into the biliary canaliculi.
The healthy liver literally swallows the contrast agent.
It does. But metastatic adenocarcinoma cells are highly dedifferentiated. They completely lack these specialized OATP transporters.
Therefore, during the hepatobiliary phase of the MRI, typically 20 minutes post-injection, the entire healthy liver parenchyma has absorbed the gadolinium and shines brilliantly bright white.
And the metastatic lesions, entirely unable to absorb the agent, remain starkly dark. They appear as sharply demarcated black holes against a glowing white background.
The signal-to-noise ratio is so profound that we can identify 3-millimeter micrometastases that a standard CT would completely miss.
That is pharmacological engineering at its finest.
Now, I have to push back on our final imaging modality,
Yeah.
the PET scan. We are constantly taught that fluorodeoxyglucose 18, or FDG-PET, is the absolute gold standard for mapping cancer spread.
It relies on the Warburg effect, yes.
The fact that malignant cells consume massive, disproportionate amounts of glucose. But the literature explicitly warns that PT is dangerously unreliable for detecting liver lesions under 1 centimeter.
Right.
If the tumor is hypermetabolic, why is the scanner failing to see it?
It is a critical limitation born entirely from the physical limitations of positron detection.
Okay, explain that for us.
Well, the PT scanner detects the high-energy gamma rays produced when a positron emitted by the radioactive fluorine annihilates with an electron in the tissue.
Right.
However, the physical spatial resolution limit of a standard clinical PD detector ring is roughly 5 to 7 millimeters. So when a lesion is smaller than 1 centimeter, the radioactive signal it emits is essentially blurred out and mathematically swallowed by the normal background metabolic activity of the massive surrounding liver.
Oh, a phenomenon defined in physics as the partial volume effect.
Precisely.
So the signal is there, but the machine's optics just aren't sharp enough to isolate it from the background noise.
Therefore, a surgeon can never rely on a PET scan to declare a liver free of sub-centimeter micrometastatic disease.
The true value of the PET scan in this context is extrahepatic staging.
You use the PET to guarantee that the cancer hasn't already spread to the lungs, the retroperitoneal lymph nodes, or the skeletal system before you commit the patient to a massive, morbid liver resection.
There is one notable exception to the PET limitations that examiners love to test, and that involves neuroendocrine tumors.
Right, because neuroendocrine metastases often have low mitotic rates. They don't consume enough glucose to trigger an FDG-PET.
For those, we pivot to gallium-68 dotatate PET imaging.
The dotatate molecule is a peptide engineered to bind with exquisite affinity to somatostatin receptors.
Which are densely overexpressed on the surface of neuroendocrine tumor cells.
And the gallium-68 isotope provides the positron for the scanner. It entirely bypasses the glucose metabolism pathway, providing highly specific functional imaging of the neuroendocrine disease burden.
So, we have utilized our molecular forensics to prove the exact histology, and we have deployed Eovist MRI and triple-phase CT to map the exact geographical borders of the disease.
The anatomical limits are set.
Now, we arrive at the ultimate definitive intervention, surgical oncology. Despite every advancement in targeted chemotherapy and radiation, physical extraction remains the undisputed gold standard for curative intent treatment of colorectal hepatic metastases.
The survival data absolutely cements that fact. A patient presenting with synchronous metastatic colorectal cancer who receives only supportive care faces a grim 5-year survival rate of roughly 5%.
With a median survival measured in mere months.
However, if that patient is anatomically resectable and we combine a curative partial apopectomy with modern adjuvant chemotherapy, that 5-year survival rate catapults to nearly 58%.
And for neuroendocrine liver metastases undergoing aggressive cytoreductive resection, the 5-year survival can exceed 60%.
We have taken a disease state that was historically viewed as a universal death sentence and redefined it as a highly complex but potentially curable anatomical and mechanical challenge.
But unlocking that 58% survival hinges entirely on the most critical mathematical threshold in all of hepatic surgery: the calculation of the future liver remnant, or FLR.
The FLR is the precise volumetric percentage of the liver that will remain fully vascularized and functionally intact after the surgeon removes the tumor-bearing lobes.
It is the absolute biological floor required to sustain human life.
For a patient with a perfectly healthy, pristine liver, the guidelines dictate a minimum FLR of 20%.
The fact that a human being can survive after having 80% of an organ amputated is an evolutionary miracle.
It is the pinnacle of regenerative biology, but that 20% threshold shifts drastically based on the underlying health of the parenchyma.
Right. If the patient has mild to moderate hepatic dysfunction, the required FLR jumps to 30%.
And if the patient has established cirrhosis, the surgeon must leave a massive 40% of the liver behind.
Let's break down the why for the listener. Why does a cirrhotic liver require double the functional reserve volume compared to a healthy liver?
It comes down to microscopic architecture and mechanotransduction. A cirrhotic liver is heavily scarred. Chronic inflammation has caused hepatic stellate cells to overproduce collagen, replacing the delicate normal lobular architecture with dense fibrotic septae.
Therefore, 40% of a cirrhotic liver by physical volume does not contain nearly the same number of functioning healthy hepatocytes as 40% of a normal liver.
Exactly. Furthermore, you have to understand the physics of hepatic regeneration. When a surgeon removes 70% of a healthy liver, 100% of the massive portal venous blood volume is instantaneously forced to flow through the remaining 30% of the vascular bed.
This massive increase in flow velocity creates immense mechanical shear stress on the endothelial cells lining the sinusoids.
And this physical shear stress is the exact trigger that forces the endothelium to release interleukin-6, tumor necrosis factor alpha, and hepatocyte growth factor.
Ah, the cytokine cascade that initiates rapid, massive cellular proliferation.
In a cirrhotic liver, the dense fibrotic scarring blunts and disrupts this portal flow, dampening the shear stress signal.
A cirrhotic liver regenerates sluggishly, if at all. If you leave less than 40%, the organ cannot handle the metabolic load, and the patient will cascade into irreversible, fatal post-hepatectomy liver failure.
We also have to account for the iatrogenic damage we inflict before the patient ever reaches the operating room.
Right. The vast majority of these patients undergo neoadjuvant chemotherapy to shrink the tumors and test the tumor biology. We're talking 4 to 6 months of heavy cytotoxic regimens like FOFOX or FOLFIRI.
Those drugs might kill the cancer, but they are brutally toxic to the background liver.
This is a critical assessment for the multidisciplinary tumor board. The oxaliplatin used in FOFX is notoriously hepatotoxic.
It specifically damages the sinusoidal endothelial cells, causing them to detach and embolize, leading to sinusoidal obstruction syndrome, or SOS.
The liver becomes painfully congested with blood.
On the other hand, the irinotecan used in FOLFIRI can induce chemotherapy-associated steatohepatitis, or CH, a severe inflammatory fatty liver disease.
Both SOS and CASH-H drastically reduce the regenerative capacity of the parenchyma, instantly pushing a theoretically healthy liver from the 20% FLR requirement firmly into the 30% risk category.
So imagine the surgeon is reviewing the 3D volumetric CT scan. The patient has a healthy background liver, but the right lobe is absolutely riddled with metastases and must be entirely resected.
The surgeon maps the cut, calculates the volume of the pristine left lobe, and realizes it only represents 15% of the total original volume.
Historically, that patient is declared inoperable. But today, we can manipulate the hemodynamics to force the organ to grow before we cut.
We use portal vein embolization, or PVE.
PVE is arguably one of the most elegant applications of interventional radiology. We are intentionally exploiting that shear stress mechanotransduction pathway we just talked about.
If the right lobe must be removed, but the left lobe is too small, an interventional radiologist accesses the portal venous system percutaneously.
They deploy physical coils and embolic glues specifically into the right portal vein, completely occluding it.
So the tumors in the right lobe are suddenly cut off from the portal flow, while the entire volume of the splanchnic venous system has to redirect somewhere.
Exactly. The entire portal blood volume is instantly shunted into the small left lobe. This sudden massive engorgement creates profound shear stress on the left lobe sinusoids.
Over the next 3 to 6 weeks, this triggers massive compensatory hypertrophy. The left lobe literally expands and grows new functional mass within the patient's abdomen.
Once a repeat CT scan confirms that the left lobe has grown past the safe 20% or 30% threshold, the surgeon takes the patient to the operating room and safely resects the right lobe.
You are basically bioengineering a new life-sustaining organ while the cancer is still actively residing in the body.
It's incredible.
Once we are actually in the operating room, we have to talk about the physical margins of resection. For decades, the untouchable dogma in surgical oncology was the 1 centimeter rule.
Surgeons believed they needed to excise a massive buffer of healthy tissue around the tumor to guarantee they captured any microscopic spread.
But the current literature has dramatically shifted. The new gold standard states that a 1 millimeter microscopic negative margin is entirely sufficient. Why did the consensus change so radically?
It represents a profound maturation in our understanding of tumor biology. We used to view metastatic invasion as a diffuse, hazy cloud of cells aggressively infiltrating outward into the healthy tissue.
Right.
But exhaustive histopathological mapping of thousands of resected specimens proved that colorectal liver metastases typically expand with a relatively cohesive, pushing border.
Oh, so the tumor compresses the surrounding healthy hepatocytes, forming a dense pseudocapsule.
It's not sending out long microscopic tentacles.
So-
Generally, no.
Therefore, as long as the pathologist confirms a true microscopically negative margin, even if there is literally only a single millimeter of viable healthy hepatocyte between the tumor edge and the surgical transection line, the local disease has been completely eradicated.
Massive, multi-institutional retrospective studies have conclusively demonstrated that achieving a 1 centimeter margin versus a 1 millimeter margin offers zero statistically significant difference in overall patient survival or local recurrence rates.
And from a surgical mechanics perspective, that 1 millimeter rule is a massive victory.
It means surgeons can preserve precious cubic centimeters of healthy parenchyma, maximizing the FLR.
It also means they can safely, meticulously dissect tumors off of major structures like the inferior vena cava, rather than declaring them inoperable just because they couldn't achieve a massive 1 centimeter buffer.
It expands the pool of resectable patients dramatically. However, just because we can resect a tumor doesn't always mean we should.
Right. The exams heavily test the clinical prognostic indicators that warn us of aggressive systemic biology where surgery might offer no survival benefit.
We look at factors like the presence of extrahepatic disease. We discussed earlier that right-sided colon primaries harbor poor prognostic mutations.
But another highly testable marker is a preoperative carcinoembryonic antigen, or CEA, level greater than 10 ngml.
Yes.
Why specifically 10 ngml? Why is that the line in the sand?
Well, CEA is a glycoprotein heavily expressed in colorectal adenocarcinomas. A serum level exceeding 10 ngml directly correlates with a massive overall biological tumor burden and active shedding of the antigen into the splanchnic circulation.
It strongly implies that the disease is not localized to just a few isolated hepatic nodules, but rather that there is likely diffuse, occult micrometastatic disease circulating systemically that our imaging simply cannot detect yet.
In these high-risk scenarios, we rely heavily on neoadjuvant systemic chemotherapy to test the biology of the tumor over time before committing to the morbidity of a major hepatectomy.
Which perfectly transitions to the intense debate regarding synchronous disease.
Yes.
The patient has a primary tumor actively sitting in their colon and metastases actively sitting in their liver. Do you perform a one-stage operation, taking both the colon and the liver in one massive, grueling surgery? Or do you perform a two-stage operation, resecting the colon, letting the patient heal, and returning for the liver later?
The data shows comparable overall efficacy, but the decision-making process is fraught. It is the ultimate test of surgical judgment.
A one-stage procedure undeniably reduces the total length of hospital stay and avoids the psychological burden of multiple major surgeries.
But it demands perfect anatomy and a patient with immense physiological reserve capable of surviving a massive combined inflammatory insult.
The decision often comes down to the behavior of the primary tumor.
Right. If the colon tumor is actively symptomatic, if it is actively bleeding, causing severe anemia, or causing a physical bowel obstruction, you have no choice.
You must resect the primary colon tumor immediately to save the patient's life from the acute complication, deferring the asymptomatic liver lesions to a second stage.
Conversely, if the primary is completely asymptomatic, many centers prefer starting with intensive neoadjuvant chemotherapy, followed by a liver-first approach.
Recognizing that the hepatic disease burden is the ultimate driver of mortality.
Exactly.
So we have explored the absolute gold standard of surgical extraction. But the grim reality of oncology is that many patients simply do not qualify.
Their tumors are wrapped intricately around the hepatic portal bifurcation, their FLR is simply too low despite PVE, or their cardiovascular comorbidities preclude major anesthesia.
When the scalpel is off the table, we have to turn to high-energy physics. We move to radiation oncology and SBRT.
And this field has evolved light years beyond the rudimentary, highly toxic whole liver radiation of the past. We're talking about stereotactic body radiotherapy, or SBRT.
SBRT is defined by the delivery of highly conformal ablative doses of photon energy in a very short, hypofractionated course.
We are no longer trying to just slow the tumor down. The goal is complete, definitive local destruction equivalent to a surgical excision.
The clinical data supporting SBRT is incredibly robust, heavily contextualized by trials like SABRE-COMET,
which evaluated ablative radiation in oligometastatic disease, defined generally as having fewer than 5 active metastatic lesions.
When applying SBRT to the liver, the local control rates are phenomenal, 87% at 1 year and maintaining 68% at 3 years.
Overall survival sits at 84% at 1 year and 44% at 3 years. Most impressively, severe grade 3 or higher toxicity is observed in less than 5% of patients.
Those statistics represent a lifeline for the medically inoperable patient. To achieve those ablative local control rates, the radiation oncologist must deliver an extraordinarily high dose.
The radiobiological evidence dictates that superior local control is strictly dependent on achieving a biologic equivalent dose, or BED, greater than 100 gray.
Let's stop and explain the concept of BED, because a PhD candidate needs to explain the mathematical model of radiobiology, not just, quote, a dose. Why do we use a calculated BED instead of just looking at the total physical dose delivered?
It's a fundamental principle rooted in the linear quadratic model of radiation cell kill. The BED mathematically accounts for both the total physical dose of photon energy and, crucially, how that dose is fractionated over time.
Normal hepatocytes and malignant adenocarcinoma cells have completely different DNA repair capacities, represented by their distinct alpha-beta ratios.
If you hit a tumor with a massive 20 gray dose in a single day, the photon energy causes catastrophic, highly clustered, double-strand DNA breaks.
The tumor cell's repair machinery is instantly overwhelmed, leading to rapid apoptotic cell death.
However, if you take that same total 20 gray dose and divide it into tiny 2 gray fractions over 10 days, the tumor cell has 24 hours between each fraction to deploy repair enzymes, fix the sublethal DNA damage, and survive.
Therefore, SBRT achieves a BED greater than 100 GG by delivering massive physical doses, often 40 to 60 gray, condensed into just 3 to 5 massive fractions.
It exploits the lack of repair time, completely physically obliterating the malignant DNA.
But delivering an ablative, organ-melting dose of photon energy to the liver introduces a terrifying mechanical problem.
The movements.
Exactly.
Wow.
The liver sits immediately beneath the diaphragm. It is intimately tied to respiration. It moves 1 to 2 centimeters inferiorly with every single breath the patient takes.
Trying to pinpoint a 1-centimeter tumor with a lethal millimeter-precise beam of radiation while the patient is actively breathing seems like trying to snipe a moving target from a moving vehicle.
It is one of the greatest engineering challenges in modern medicine. You cannot use a static CT scan for simulation. The planning must incorporate the fourth dimension, time.
We utilize 4D CT scanning, which actively tracks the physical trajectory of the tumor through the entire respiratory cycle.
So the computer builds a 3D model of exactly where the tumor is at maximum inhalation, maximum exhalation, and every point in between.
Yes. And we employ mechanical techniques to limit that motion, such as applying physical abdominal compression devices to blunt the diaphragm's excursion.
But the true technological marvel is respiratory gating.
Right. The linear accelerator, the massive machine generating the photon beam, is actively synchronized to a monitor tracking the patient's breathing pattern.
The machine is programmed to only fire the beam during a specific, stable phase of the respiratory cycle, typically deep expiration.
The millisecond the patient breathes in and the tumor moves out of the predefined crosshairs, the beam instantly shuts off.
We further enhance this precision using implanted fiducial markers. Interventional radiologists place tiny gold seeds directly inside the tumor prior to treatment.
The linear accelerator's onboard imaging system tracks the exact spatial coordinates of those gold seeds in real time, adjusting the beam on the fly.
We also utilize volumetric modulated arc therapy, or VMAT, where the machine rotates continuously 360 degrees around the patient,
Dynamically modulating the beam's intensity and shape to perfectly sculpt the high-dose radiation cloud exclusively to the contours of the tumor.
But despite all of that incredible technology, the photon beam still has to travel through normal, healthy liver tissue to reach the target.
And this brings us to the absolute nightmare complication of hepatic radiation. Radiation-induced liver disease, or ILAL.
ILD is a catastrophic event. It is essentially a severe radiation-induced form of veno-occlusive disease.
The high-energy photons cause acute damage to the delicate endothelial cells lining the central veins of the hepatic lobules.
These damaged cells physically slough off into the microscopic lumen, triggering a massive coagulation cascade.
The veins become completely occluded with microthrombi. The liver becomes acutely congested, heavily enlarged, and rapidly fails, presenting with massive ascites, severe jaundice, and an unacceptably high mortality rate.
To prevent RLD, medical physicists rely on incredibly strict dosimetric constraints, specifically the Task Group 101, or TG-101 guidelines, published by the American Association of Physicists in Medicine.
And there is one metric that is universally tested: the preservation of the 700 cc sanctuary.
The TG-101 constraint dictates that the absolute volume of normal, healthy liver receiving less than 15 gray must be greater than 700 cubic centimeters during a 3-fraction SBRT course.
If the protocol is 5 fractions, the constraint shifts to 700 cc receiving less than 21 gray.
The logic here is brilliant. Instead of agonizing over the maximum hotspot dose the tumor receives, the physicist focuses entirely on protecting a guaranteed safe zone.
Exactly. The human body requires roughly 700 cc's of functional hepatic parenchyma to maintain baseline metabolic homeostasis.
By mathematically ensuring that a contiguous 700 cc volume receives a biologically sublethal dose, the physician guarantees that regardless of how completely the targeted regions are ablated, the patient will have enough functional reserve to avoid RLD and survive the therapy.
When a patient presents with massive diffuse metastatic burden, dozens of tumors, where guaranteeing a 700 cc sanctuary is physically impossible, SBRT is entirely contraindicated.
We have to step down to palliative therapies. We can offer whole liver conventional radiation, delivering very low, gentle doses of roughly 8 to 21 gray, divided into 1 to 3 fractions.
The clinical goal shifts entirely from cure to palliation. Palliative whole liver radiation offers zero statistically significant overall survival benefit.
However, for a patient with a massively distended liver capsule suffering from intractable, agonizing pain, this low-dose radiation provides profound symptom relief in up to 80% of cases.
The critical metric to remember for standard, conventionally fractionated external beam radiation is that the threshold for inducing RLD sits around 30 gray. You must stay well below that ceiling.
So we have utilized the physical scalpel, and we have utilized the external photon beam. Now we arrive at our final therapeutic frontier: trans-arterial and hyperthermic ablative modalities.
If we cannot safely cut the tumor out, and the anatomy precludes safe external radiation, we go back to the very beginning of our discussion.
We attack the tumor from the inside by exploiting its own neoangiogenic plumbing.
Trans-arterial radioembolization, or TAR. This is the ultimate weaponization of the tumor's hemodynamic schist.
We know the metastatic adenocarcinoma relies almost exclusively on the hepatic artery. TAR exploits this by injecting thousands of microscopic radioactive glass or resin spheres directly into the arterial branch, feeding the tumor.
The radioactive isotope deployed here is yttrium-90, or Y90, and understanding the specific physics of Y90 is crucial for the FRCS candidate.
Y90 is a pure beta emitter. Beta particles are essentially high-energy electrons ejected from the nucleus.
Unlike the high-energy X-ray photons used in SBRT that shoot straight through the patient's body, beta particles possess mass and charge. They dump all of their destructive kinetic energy into the surrounding tissue incredibly quickly.
That rapid energy transfer is the key to its safety and efficacy. The maximum physical tissue penetration of a Y90 beta particle is roughly 11 millimeters, with an average penetration of just 2.5 millimeters.
When the interventional radiologist injects the spheres, they physically lodge deep within the chaotic hypervascular capillary bed of the tumor.
They act as thousands of microscopic internal radiation sources, delivering a devastating, highly localized dose that literally burns the tumor from the inside out.
But because the radiation only travels a few millimeters, the healthy portal-fed hepatocytes sitting just half a centimeter away are largely spared.
Furthermore, Y90 has a short half-life of 64.2 hours. It delivers its massive payload continuously over roughly 2 weeks, and then decays safely into stable, non-radioactive zirconium-90.
But the inclusion criteria for TARE are incredibly rigid. The patient must have an Eastern Cooperative Oncology Group, or ECOG, performance status of 2 or less, meaning they are ambulatory and capable of self-care.
But the absolute contraindications are where the complexity lies. You are strictly forbidden from performing TARE if the patient's total bilirubin exceeds 2 milli-GDL, or if they are classified as child-PUC class C.
Those contraindications exist because they indicate that the background liver is already in a state of severe decompensated failure.
While Y90 is highly targeted, there is inevitably some microscopic collateral radiation to the surrounding tissue.
If the liver's already failing, that tiny collateral insult will push the patient over the precipice into irreversible terminal hepatic failure.
The other major contraindication revolves around pulmonary shunting. A patient is disqualified from TAR if they demonstrate greater than 20% lung shunting, or if the calculated radiation dose to the lungs from a single application would equal or exceed 30 gray.
Why are we suddenly meticulously calculating lung doses for a targeted liver therapy?
Because the neoangiogenesis created by the tumor is completely chaotic and functionally incompetent. The tumor rapidly builds disorganized vascular networks that frequently lack distinct capillary beds, resulting in massive direct arteriovenous shunts.
So the high-pressure arterial blood flows directly into the low-pressure venous drainage without ever passing through a filtering capillary web.
Exactly. If an interventional radiologist injects millions of radioactive microspheres into the hepatic artery, and the tumor has a massive AV shunt, a large percentage of those spheres will completely bypass the tumor tissue.
They will shoot directly into the hepatic veins, flow up the inferior vena cava, travel through the right atrium and right ventricle of the heart, and be pumped directly into the delicate capillary beds of the lungs, where they will permanently lodge.
This will irradiate the lungs from the inside out, causing a fatal radiation pneumonitis.
To prevent this, every single patient must undergo a rigorous mapping angiogram weeks before the actual treatment.
The radiologist injects a harmless surrogate tracer, technetium-99 meter labeled macroaggregated albumin, or MAA.
The MAA particles are physically identical in size and dispersion dynamics to the Y90 spheres.
The patient is immediately taken for a SPECT scan to measure exactly what percentage of the MAA escaped the liver and lodged in the lungs.
If the SPECT scan calculates that more than 20% of the MAA bypass the liver, the anatomy is deemed too dangerous, and the patient is permanently disqualified from TAR.
If the shunt fraction is safe, the medical physicist utilizes that exact percentage to calculate the individualized Y90 dose.
For candidates using the TheraSphere glass microsphere system, you must know the dosimetry equation. A equals 120 multiplied by M, all divided by the quantity of 1 minus S, multiplied by 50.
Let's break down the variables of this equation because it perfectly encapsulates the biophysics of the therapy.
A represents the required activity of the yttrium 90 in gigabecquerels. The target goal is to deliver a massive tumoricidal dose of a 120 gray to the tissue.
M is the physical mass of the targeted liver lobe or segment in kilograms, derived directly from the volumetric CT scan data.
And S is the exact lung-liver shunt fraction calculated from the MAA mapping study. The denominator heavily weights the equation based on the shunt fraction.
As the shunt fraction increases, the equation mathematically down-titrates the allowable administrable activity, strictly capping the dose to guarantee the lungs never receive an unsafe level of radiation.
When we look at the clinical outcomes for TAR, the data is highly nuanced. The landmark SURFLUX trial investigated adding Y90 to standard first-line chemotherapy in treatment-naive patients with metastatic colorectal cancer.
Surprisingly, it failed to demonstrate a statistically significant improvement in overall progression-free survival compared to chemotherapy alone.
However, it did show a highly significant delay in tumor progression, specifically within the liver.
That trial brilliantly highlights the fundamental biological truth of this disease. Hepatic metastases are a local manifestation of a systemic problem.
TAR provides spectacular local control within the liver. However, if the patient harbors microscopic occult disease in the lungs or bone marrow, that systemic disease will continue to relentlessly progress, driving the overall survival curve down.
TAR shines brightest in the second-line setting. For patients whose tumors have grown resistant to first-line systemic chemotherapy, combining TAR with a second-line regimen significantly improves both overall and hepatic-specific progression-free survival.
We must also briefly cover TACE trans-arterial chemoembolization. It utilizes the exact same anatomical access and mapping procedures, but the payload is completely different.
Instead of radioactive glass, the interventional radiologist injects calibrated synthetic beads that have been heavily loaded with cytotoxic chemotherapy, most commonly irinotecan.
TACE is a dual mechanism attack. The beads physically occlude the arterioles feeding the tumor, instantly inducing severe local ischemia and hypoxia.
Simultaneously, over the next several weeks, the beads slowly leach their highly concentrated payload of irinotecan directly into the starving tumor tissue.
Phase 3 randomized controlled trials have demonstrated that combining systemic FOLFIRI with intra-arterial irinotecan-eluting beads produces significantly higher objective response rates and improved overall median survival compared to relying on systemic FOLFIRI alone.
The primary complication for both TAR and TACE that examiners will ask about is post-radioembolization or post-embolization syndrome.
It is a severe inflammatory response characterized by profound fatigue, nausea, fevers, and abdominal pain, driven by the massive release of cytokines as the targeted tumor undergoes massive rapid necrosis.
The other critical complication to recognize is the risk of non-target embolization. If the interventional radiologist does not meticulously identify and coil off tiny collateral arterial branches, the radioactive or chemo-loaded spheres can reflex backward
And enter the cystic artery or the right gastric artery, leading to catastrophic radiation cholecystitis or massive, full-thickness gastric ulceration and perforation.
Okay, we have arrived at our final subtopic, hyperthermic ablation. When a patient has a highly limited disease burden, perhaps just 2 or 3 small tumors, but surgery is anatomically impossible and external radiation is contraindicated, we can literally bypass the vascular system entirely.
An interventional radiologist percutaneously drives a rigid needle probe straight through the abdominal wall, directly into the geographic center of the tumor, and intentionally cooks the malignant cells to death.
We are aiming to generate intratumoral temperatures exceeding 60 degrees Celsius. At this critical thermal threshold, cellular proteins instantaneously and irreversibly denature.
The lipid bilayers of the cell membranes melt and rupture, and the entire targeted volume undergoes complete, immediate coagulative necrosis.
There are 2 competing modalities here, and a PhD candidate must be able to fluently explain the distinct physics governing each: radiofrequency ablation, or RFA, and microwave ablation, or MWA.
When I look at RFA, the legacy technology, my understanding is that the probe itself isn't actually hot. The machine passes a high-frequency alternating electrical current, around 375 to 500 kilohertz, down the uninsulated tip of the electrode.
That is precisely how it works. The alternating current interacts with the tissue's natural ions, primarily sodium and chloride.
As the electrical field rapidly oscillates hundreds of thousands of times per second, the tissue ions attempt to align and realign with the alternating current.
This rapid, chaotic ionic oscillation creates intense physical friction at the microscopic level. It is the patient's own tissue generating the heat through ionic friction.
But from a pure biophysics and engineering standpoint, trying to generate friction-based heat inside a massively vascularized organ like the liver seems incredibly inefficient.
The liver is essentially a giant radiator filled with flowing blood. And this introduces RFA's massive Achilles heel: the heat sink effect.
I always conceptualize this as trying to boil a pot of water while a freezing cold, rapidly flowing river is rushing directly against the side of the pot.
The heat sink effect is the primary reason RFA fails. If a metastatic tumor is located immediately adjacent to a major vascular structure, like the right hepatic vein or the main portal buckle, that massive volume of body temperature blood rushing past the tumor acts as a physical heat sink.
It continuously and rapidly draws the thermal energy away from the tissue. The tissue immediately abutting the blood vessels simply never reaches that lethal 60-degree threshold.
Viable microscopic tumor cells are left behind along the vascular margin, leading to unacceptably high local recurrence rates, historically ranging anywhere from 10% to over 30%.
Which is exactly why the field is rapidly pivoting to microwave ablation, or MWA. MWA operates on a completely different physical principle. It utilizes electromagnetic microwaves at drastically higher frequencies, typically 0.915 to 2.45 gigahertz.
MWA abandons ionic friction entirely and instead relies on dielectric hysteresis. The electromagnetic microwave field causes the polar water molecules naturally abundant within the tumor tissue to continuously flip back and forth, attempting to align with the microwave field billions of times per second.
This massive, instantaneous kinetic energy generates significantly higher intertumoral temperatures, and it does so drastically faster than RFA.
Because the thermal energy is generated so intensely and rapidly, it completely overwhelms and defeats the cooling capacity of the adjacent blood flow.
MWA experiences a profoundly mitigated heat sink effect, resulting in far more reliable spherical ablation zones and significantly lower local recurrence rates, often quoted between 5% and 13%.
MWA also allows the radiologist to simultaneously fire multiple probes arrayed around a larger tumor, synergistically generating massive ablation zones.
However, regardless of whether you use RFA or MWA, the literature enforces rigid anatomical constraints. Thermal ablation is fundamentally restricted to patients presenting with fewer than 5 discrete tumors, and crucially, every single tumor must measure less than 3 centimeters in maximum diameter.
That 3 centimeter threshold is an absolute non-negotiable dividing line in interventional oncology. Above 3 centimeters, the biophysics of thermal dispersion simply break down.
The energy cannot reliably penetrate to the outer periphery of a larger spherical mass to guarantee complete microscopic coagulative necrosis. If you attempt to ablate a 4-centimeter tumor, the local control rate plummets from a highly respectable 85% down to a dismal 39%.
However, for lesions strictly under 3 centimeters, the ultimate role of thermal ablation is currently the subject of intense field-defining research.
The ongoing Collision trial is a massive, prospective, randomized non-inferiority study directly comparing thermal ablation head-to-head against the gold standard of surgical resection for small colorectal liver metastases.
If the data ultimately proves that sticking a microwave probe into a 2-centimeter tumor yields the exact same 5-year overall survival as subjecting the patient to a major surgical hepatectomy, it will trigger a tectonic paradigm shift in how we approach oligometastatic disease.
What an absolute marathon of biology and physics we have just navigated. We have systematically deconstructed the entire molecular and hemodynamic landscape of metastatic liver cancer.
We started by exploring the massive physiological trap of the portal venous system and analyzed exactly how an invading tumor manipulates local VEGF gradients to hijack the hepatic artery, building its own high-pressure, oxygen-rich survival pipeline.
We dove deep into the molecular forensics of the pathology lab, exploring how distinct embryological origins dictate the expression of cytokeratins and dictate why a BRAF-mutated right-sided colon cancer behaves so aggressively.
We detailed the precise pharmacokinetics of hepatobiliary imaging, explaining why dedifferentiated tumors appear as stark black voids against a glowing, eovist-filled normal liver.
We confronted the brutal mathematics of surgical resection, dissecting the absolute necessity of maintaining a 20%, 30%, or 40% future liver remnant and breaking down how the sheer stress of portal vein embolization forces the organ to literally regrow itself.
We challenged the old surgical dogmas, explaining why a 1-millimeter microscopic margin is now considered ontologically sound.
And when surgery was anatomically impossible, we turned to the linear accelerators. We unpacked the linear quadratic model of radiobiology, defining why an SBRT protocol must achieve a BED over 100 gray to shatter tumor DNA, while meticulously calculating respiratory motion and protecting our 700 cc sanctuary to prevent fatal veno-occlusive RLD.
We broke down the exact asymmetry of yttrium-90, calculating the life-or-death math of pulmonary shunting. And finally, we contrasted the ionic friction of RFA against the immense heat-sink defeating power of dielectric hysteresis in MWA.
We have covered the precise depth of knowledge required to not merely memorize a treatment algorithm, but to fundamentally understand the underlying physics, molecular signaling pathways, and surgical anatomy that govern these advanced therapies. But before we conclude, I want to pivot back to one specific concept we discussed earlier because it represents the true bleeding edge of this field.
Okay, let's hear it.
We spent significant time detailing the liver's miraculous ability to regenerate up to 80% of its mass following a major resection. We established that this massive hypertrophic response is driven by sheer mechanical portal stress on the sinusoidal endothelium, which triggers a highly specific cascading release of interleukin-6, TNF-alpha, and hepatocyte growth factor.
Right.
Consider what manipulating that specific mechanotransduction pathway means for the future of regenerative oncology. If we can completely sequence and map that exact molecular signaling cascade, could we eventually synthesize those specific cytokines?
Could we develop a targeted pharmacological therapy to instantaneously and purposefully trigger the regeneration of healthy liver tissue that we have intentionally damaged with our own aggressive SBRT radiation or TACE chemoembolization treatments?
The ultimate definitive cure for metastatic liver disease might not solely lie in engineering hotter, more toxic, and more destructive ways to obliterate the tumor cells. It might ultimately lie in finally mastering the human organ's own ancient evolutionary capacity to endlessly rebuild itself around the damage we inflict.
That is a profoundly powerful concept to carry with you into the exam room or the laboratory. The future of surgical oncology isn't merely physical destruction, it is directed molecular regeneration. If you are preparing for your FRCS exams or if you are stepping up to defend your PhD thesis, remember that your examiners are not looking for someone who can just recite a flowchart.
They want to see that you comprehend the deeply interconnected biophysics, the embryology, the hemodynamics, and the microscopic architecture that we have explored today. Understand the why, and the what becomes obvious.
Keep digging into the literature, keep questioning the established consensus, and best of luck on your upcoming examinations. You have absolutely got this.